Good afternoon, everyone. Center of Excellence at RIMS Imphal, Manipur welcomes all the participants for today's RDLS session. Today's topic is integration of NCD screening and management among PLHIV at the ART centers, and the speaker is Dr. N. Reema. Dr. N. Reema ma'am is the assistant professor with the Department of Medicine at COE RIMS. She is also the SASEP member. We welcome you, ma'am, for today's session and request you to start the session.
So thank you for welcoming me. Good afternoon, everyone. So today the topic of our discussion is integration of non-communicable disease screening and management among people living with HIV at ART centers. So we'll just see the background of HIV and non-communicable diseases. Common non-communicable diseases like hypertension, diabetes, coronary artery disease, and stroke, and their pathogenesis. We'll do the screening and assessment of non-communicable diseases, integration of non-communicable disease care with non-national AIDS control program, and implementation of integration of non-communicable disease care to people living with HIV at ART centers, how to proceed further. So non-communicable diseases among people living with HIV, there is widespread access to antiretroviral therapy or ART that has transformed HIV disease threatening condition to manageable chronic conditions. So the demographic of ARTC is changing. There is significant proportion of people living with HIV greater than 50 years. That is, aged people living with HIV is on increase due to greater longevity of this drug due to arrival of advanced ART drugs. And people living with HIV facing different health challenges due to aging are more likely to develop some or the other non-communicable diseases. So non-communicable diseases are one of the leading causes of non-AIDS related morbidity and mortality in people living with HIV. So detection and timely management of non-communicable disease in PLHIV is very, very critical. So some common non-communicable diseases are, as we all know, in cardiovascular system, we have hypertension, ischemic heart disease, stroke, rheumatic heart disease, and respiratory asthma, COPD, occupational lung disease, cystic fibrosis, pulmonary hypertension, endocrine, and various types of diabetes, type 1, type 2, pre-diabetes, gestational diabetes mellitus in pregnancy, and renal in chronic renal disease. And central nervous system or psychiatric like depression, anxiety, schizophrenia is also prevalent in PLHIV. And in blood is anemia, mainly nutritional, but some hemoglobinopathy may also be there. Cancers, breast cancer, cervical cancer, lung cancer, oral cancer, prostate cancer, colon stomach cancer, and some blood cancer, like leukemia, lymphoma also there. And musculoskeletal problem like arthritis is also prevalent in such patients. So the overall prevalence of diabetes is 11.49 and the prevalence of pre-diabetes is 15.3 and hypertension is 35.5 and generalized obesity is 28.6 and abdominal obesity alone is 39.5. Dyslipidemia was also found among 81.2%. All the metabolic non-communicable disease except pre-diabetes were more frequent in urban areas as compared to rural areas. The charts are given below. So the important ones are coronary artery disease, cerebrovascular disease, peripheral artery disease, rheumatic heart disease, deep vein thrombosis, and pulmonary embolism. So these cardiovascular diseases are a group of disorders that can lead to heart attack and stroke. So this is number one, cardiovascular disease are the leading cause of death worldwide. 1 out of 3 deaths worldwide are due to cardiovascular disease, and 3 out of 4 deaths from cardiovascular disease occur in low and middle income countries. So there is an increasing burden over low and middle income countries, and they also face double burden of communicable as well as non-communicable diseases, limited access to effective and equitable healthcare services, and delay in detection and treatment. All these conditions can lead to overburden, less resilient health system, high productivity losses from premature death and disability, and strained economic development. So the factors responsible for cardiovascular disease in India are the various CVD epidemics in India occur due to population level changes and due to increased biological risks. In population level changes, 6 major transition occurs in the case of epidemiological, demographically, environmental, socio-cultural, nutritional, and economic. And while increased biological risks occurs in early life influences, inherent biologic and genetic differences. So the risk factors in cardiovascular diseases, as we all know, hypertension, diabetes, dyslipidemia, that is high fasting, total cholesterol, a total low density lipoprotein or triglycerides, and obesity, that is measured by BMI greater than 25 kg per meter square for Indian population. Increased waist circumference is also important. In case of obesity, like men is 102 and women is 88. So as stated by WHO, waist circumference greater than 94 centimeter in men and 80 centimeter in women is associated with increased risks of metabolic complication like diabetes, metabolic syndrome, and all. And this risk significantly increases with waist circumference greater than 102 in men and 88 in women. So physical inactivity, tobacco use, excessive alcohol consumption, unhealthy diet and nutrition, family history of cardiovascular disease. These are all the risk factors for cardiovascular diseases. So a concept of opportunistic screening is for early detection of disease, for early management of disease, including lifestyle changes and pharmacological therapy, and improve the health and well-being of patient and prevent comorbidities. So National Technical Guidelines said the overall aim is early identification of non-communicable disease among people living with HIV, thereby reducing morbidity and mortality associated with non-communicable disease among PLHIV by providing integrative and comprehensive management of HIV and non-communicable disease in routine program setting. So assessment is very important. Assessments can be done at the time of registration in HIV care of ART or ART initiation, that is first visit and 6 months of ART, and should be repeated every 6 months thereafter. So we should ask for the history of heart disease, stroke, diabetes, or hypertension, any symptoms of angina, breathlessness of exertion, breathlessness or lying down fade, numbness or tingling sensation over limbs, indicating diabetes, and loss of weight, increased thirst, polyuria, and puffiness of face, passing blood in urine. Pertaining to chronic kidney disease. So any past, present treatment and any medication is going on with patient, current or past tobacco use or alcohol consumption, whether lifestyle is sedentary or active, or premature heart disease or stroke in a first degree relative history is there. So, and after this history on examinations, we have to assess this body mass index or BMI and waist circumference. We have to measure the BP. We have to see for the signs and symptoms of diabetes mellitus. And we have to examine for signs such as pitting edema, heart murmur, basal capitation in lung, tenderness in abdomen. And also we have to assess lipid profile. So screening and early detection. ART centers have screened people living with HIV for diabetes, hypertension, cardiovascular disease, and common cancers, and identify individuals who are at risk of this non-communicable disease, but warranting further investigation or action. So screening shall involve simple history, like family history of diabetes, history of alcohol, tobacco, and dietary habits, and general physical examination, calculation of BMI, BP monitoring, blood sugar estimation, etc. So routine screening and management of mental health disorders like depression, psychosocial stress should be provided for PLHIV in order to optimize these health outcomes and improve the adherence to ART. So first, we'll discuss this hypertension screening, diagnosis, and initial management for adult with PLHIV. So screening of hypertension in adult PL with HIV. So all PLHIV above 18 years should undergo screening by healthcare providers to BP measurement at registration into HIV care or ART initiation every 6 months after an ART initiation, or separately as a screening examination if requested by people living with HIV or the need felt by the healthcare provider based upon the symptoms. So hypertension screening is very important. We have to follow some rules and regulations during the screening to give the accurate measurement of blood pressure. So there should be no talking during and before measurement. The cuff should be at the level of heart level, should be at the level of heart, and we should use correct cuff size and positioning. Cuffs are of small, medium, and large. So we have to use the correct cuff size such that the bladder encircles 80 to 100% of this upper arm, and the cuff bladder width should be at least 40% of the upper arm circumference. Ensure cuff is on bare arm and over thin layer of clothing if it's unable to remove the clothing. And we have to avoid bunching of clothes under the cuff. The back should be supported, arm should be supported, and record the exact reading. Do not just round off. And legs should be uncrossed and feel unsupported. So preparation of the patient, as stated above, is very important, and the patient should also avoid tea, coffee, exercise, and tobacco use for at least 30 minutes before measurement to prevent erroneous result. And the patient should have rested for at least 5 minutes before measurement. Ensure he has emptied his bladder so that he can feel comfortable. And when taking blood pressure, the patient should be seated with back supported, both feet resting on the ground. And the patient should not speak while BP is being measured, because there are lots of variation in BP according to this methods of taking BP. And so diagnosis of hypertension in adult PLHIV should be done by a physician or staff nurse using a validated device and standardized BP measurement procedure, and should be based on at least 2 measurements taken on at least 2 visits, which are at least 1 to 4 weeks apart. So we should not advise this antihypertensive medication on first visit itself, except in some other condition. Hypertension is diagnosed during the first measurement in case of hypertensive urgency and hypertensive emergency. So what is hypertensive urgency? That is when systolic BP is greater than 180 millimeter of mercury, and or diastolic BP is greater than 110 millimeters of mercury with no evidence of acute target or organ damage. And hypertensive emergency is systolic BP is greater than 180 millimeters of mercury, and or diastolic BP greater than 110 to 120 millimeters of mercury and associated with cardiovascular, cerebral, renal damage, or grade 2, 3, and 4 retinopathy. So where hypertension is diagnosed during the first measurement itself. So hypertensive urgency, only systolic and diastolic BP will be raised with no evidence of target and organ damage. And hypertensive emergency will be same exacerbated with systolic and diastolic BP along with an organ damage. So hypertension should be diagnosed when BP is persistently above a systolic of 140 millimeters of mercury and or diastolic of 90 millimeters of mercury. So additional investigation, if available, we can do fasting blood sugars, that is for assessment of diabetes. Urine analysis, lipoproteinuria may be early indication of diabetic nephropathy and a marker for higher risks of cardiovascular morbidity and mortality. And desirable for PLHIV with systolic BP greater than 160 millimeters of mercury and or diastolic BP greater than equal to 100 millimeters of mercury. We can do lipid profile, because this lipidemia is a cardiovascular risk factor, and serum creatinine, sodium, potassium, that is assessment for renal function, and ECG for end organ damage like left ventricular hypertrophy or any myocardial infarctions. So management of hypertension in adult PLHIV, we have to give the target for BP control. So target for BP control for patient below 80 years is systolic BP less than 140 millimeter of Ag and diastolic BP less than 90 millimeter of Ag. And for patient 80 years and older is less than 150 millimeter of systolic and less than 90 millimeter of diastolic, because strict restriction of BP will lead to giddiness, vertigo, and postural hypertension in case of elderly. So BP less than 150 by 90 is taken as quite a good control of BP for patient older than 80 years. So all the patients require lifelong lifestyle modification, including dietary changes to healthy hard diet, salt limited to 5 to 6 gram per day, low fat diet, regular exercise, weight maintenance with target BMI of 18.5 to 22.9, that is normal BMI range, and smoking cessation. So management of hypertension, antihypertensive therapy for uncomplicated hypertension, and irrespective whether HIV status is either mono or combination therapy, we can start with an angiotensin converting enzyme AC inhibitor like enalapril, ramipril, angiotensin receptor blockers like losartan, telmisartan, olmesartan, calcium channel blockers like amlodipine, cilnidipine, thiazide hydrochlorothiazide, beta blockers like atenolol. So this will be given to the patient according to the condition or any other comorbidities of the patient. So management as such is according to the grading of the hypertension. That is grade 1, grade 2, grade 3 hypertension. Grade 1 is systolic BP is 140 to 159 and diastolic is between 90 to 99. So here we can try a lifestyle modification for 3 months as stated above, especially stalls restrictions. And if this is not responding to lifestyle modification alone, then we can try for one drug pharmacotherapy with all the drugs we have listed before. In grade 2, systolic BP 160 to 179 and diastolic 100 to 109. We have to give one drug pharmacotherapy and along with lifestyle modification, because in this category only lifestyle modification won't help. And grade 3 is greater than 179 and diastolic is greater than 110. Here, 2 drugs pharmacotherapy with lifestyle modification is a must. So, care provision and referrals. Screening, diagnosis, treatment of uncomplicated hypertension can be provided by a trained medical officers. Grade 3 hypertension or failure to achieve treatment goals following initiation and dose increase of 2 antihypertensive to a maximum level should be referred to the physician experienced in the management of hypertension. And such uncontrolled hypertension, in spite of being on multiple drugs, should also rule out renal artery stenosis by doing ultrasound Doppler and also rule out CKD, chronic kidney disease. Immediate referral to appropriate facility and provider should be done in cases of hypertensive urgency and especially hypertensive emergency. We need to lower down the BP soon in case of hypertensive emergency also. The various drugs used for hypertensive emergency like nitroglycerin, labetalol, esmolol, nifedipine, enalapril. There are various drugs used for hypertensive emergencies. So next, let's move on to diabetes mellitus screening, diagnosis and initial management for adult PLHIV. So screening, all the patients living with HIV should undergo screening through RBS, that is random blood glucose test, and registration into HIV care or ART initiation. 1 to 2 months after ART initiation, then after every 6 months, we have to see RBS. At a change of regime, switch or substitution of regime, or separately as a screening examination if requested by the person. So while screening, we have to look for the symptom of diabetes like polyuria, polydipsia, weight loss despite polyphagia, tiredness, weakness, generalized pruritus, recurrent urogenital infection, delayed healing of wound. So if the patient has any of these symptoms, we have to rule out diabetes. Diagnostic criteria for diabetes is symptom of diabetes plus random blood glucose greater than or equal to 200 milligram per deciliter and fasting blood glucose greater than or equal to 126 milligram per deciliter, while 2-hour postprandial or 2-hour post 75 gram glucose, that is for glucose tolerance test, is greater than 200 milligram per dl, and glycated hemoglobin greater than or equal to 6.5%. So diabetes diagnosed using any of these criteria should be confirmed with another test subsequently. So screening for diabetes is done by random blood glucose, which is measured at any time of the day without regard to time since last meal. It's easier to perform but less sensitive than other tests. So the purpose of screening RBS over 140 is taken as requiring further follow-up. And the preparation, the mode of taking this RBS is also very simple. We have the items needed, our glucometer and Lancer device. We have to turn on glucometer, insert a test strip at end of glucometer. You have to prick the finger with the lancet and gently squeeze the finger to get a drop on the test strip and wait for the meter to give the reading and record the result. This is very easy way. And diabetes and fasting, as I mentioned above, it should be greater than or equal to 126 milligram per dl, and postprandial should be greater than 200 milligram per dl, and HbA1c greater than 6.5 milligram per dl should be diagnosed as diabetes, type 2 diabetes. So monitoring of diabetes mellitus in adult PLHIV. So fasting and 2-hour postprandial at least should be used if the values are at least once monthly or after every 3 months if the values are not in the normal range. So HbA1c at least 6 to 12 months if available, more often every 3 months if the value is not in the ideal target range. Clinical examination should be done at every visit, minimum every 3 monthly visit, and screening for long-term complication like retinopathy, nephropathy, neuropathy, perivascular disease, coronary artery disease should be done at least once in 6 months, more often if needed according to the patients. So we have to optimize the weight, we have to optimize the waist circumference, BP, and lipids also. And routine examination of the food should be done every visit, and education regarding the food care should be given to the patient at each visit. We have to see if the patient has loss of sensation of hot and cold due to neuropathy, and if the patient has any swelling or redness or any color change of the skin of the food. We have to see, we have to rule out any infections, especially on the web of the toes. We have to keep them dry and clean. We have to wash the food regularly. We have to trim the nail regularly also to prevent any type of infections. So there are so many. You have to wear comfortable shoes also for such patients to prevent diabetic foot, and discourage tobacco use and excess use of alcohol. So additional investigation, if available, we can do lipid profile, serum creatinine, urine analysis for proteinuria. For diabetic nephropathy is also very prevalent. And care and provision and referrals. So screening, diagnosis, management through lifestyle modification can be provided by trained medical officers. And initiation of oral hypoglycemic shall be done by physician. Continuation of treatment can be provided by trained medical officers in PLHIV with controlled diabetes. And management and follow-up by physician are recommended in patient with uncontrolled hypoglycemia, despite maximum dose of metformin, sulfonylureas, patient with foot ulcers, patient with visual impairment, with uncontrolled hyperglycemia, and patient may also need multiple drugs therapy, or patient may also need insulin. Next, move on to cardiovascular disease risk factors, screening, assessment, and initial management for adult people living with HIV. So we all know the cardiovascular risk factors like hypertension, diabetes mellitus, dyslipidemia, obesity, increased waist circumference, physical inactivity, tobacco use, and excessive alcohol consumption, unhealthy diet, nutrition, family history of some cardiovascular disease. Anthropometric measurement is very important because screening for obesity, that is by body mass index, it is a screening tool estimating total body fat content in a person's body. It's calculated by dividing a person weight in kilograms or by his height in meter square. This is kg per meter squares. So obesity. So criteria for diagnosis of obesity is obesity BMI is categorized according to ICMI guidelines into following categories. That is underweight if BMI is less than 18.5, and 18.5 to 22.9 is normal BMI, 23 to 24.9 is overweight, and obesity is greater than or equal to 25 kg per meter square. And central obesity, that is waist circumference of greater than 90 for men and greater than 80 for women. Mental health is also very prevalent in people living with HIV. So let's discuss a brief idea about this. So people living with HIV are prone to psychosocial elements due to HIV per se, or due to a patient experiencing HIV in the surrounding. People living with HIV may face multiple types of psychosocial issues like depression, anxiety, and internalized stigma, etc. Any such issues can significantly hamper adherence and mental well-being of the patient. And depression is 2 or 3 times more prevalent in people living with HIV than in general population. So screening for depression among people living with HIV is very, very important. So all people living with HIV should receive basic training for depression before initiating ART. Thereafter, every 6 months, using the following 2 questions. During the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? During the past week, have you often been bothered by little interest or pleasure in doing things? So thorough screening for depression using Patient Health Questionnaire 9, which we'll discuss in further slides, screening tool and scoring pattern for PLHIV, answering yes to any of this question. So this is Patient Health Questionnaire number 9. Over the last 2 weeks, how often have you bothered by any of this problem? Yeah, not at all, several, more than half of the days, every day. So the number first is little interest or pleasure in doing things. We can rate according to the patient. And feeling down, depressed, hopeless, trouble falling and staying asleep or sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself or that you are a failure or have let yourself or family down, trouble concentrating on things such as reading newspaper or watching television, moving or speaking so slowly that other people could have noticed, or opposite being so fidgety, restless that you have been moving around a lot more than usual, then thoughts that you have been better off dead or hurting yourself in a way. So we have to rate the scale according to the answers. So total scoring is 0 to 4 is depression is unlikely, and we have to repeat the screening as per schedule. 5 to 9 is mild depression, and we have to provide supportive counseling and continue to monitor. If the patient is on efavirenz, we have to start with a different ARV drugs after ruling out treatment failure. 10 to 14 moderate depression, we have to provide counseling through the trained counselor, and same for 5 to 19 and 2 to 27, that is severe depression. If the patient is on efavirenz, substitute with different ARV drugs after ruling out treatment failure, and we have to refer to psychiatrists for further assessment and some antidepressant medications. So key supportive counseling messages in people living with HIV with depression is, first is psychosocial support, then self-management skill and how to reduce stress. Psychosocial support, we have to explain about depression, assure that it can be managed. Feeling of hopelessness, worthlessness, negative emotion are a part of depression and will revert with proper counseling and treatment. Inform on course of counseling and treatment. Identify supportive family members, involve them as appropriate. Involving peers and community support group is also helpful. And self-medicines mean we have to continue ART as prescribed. We have to Identify activities that you have to find interesting, pleasurable, encourage participation in these activities, get regular and sufficient sleep, approximately 7 to 8 hours. Physical activity has to be increased, and we have to contain ART or healthcare facility immediately if thoughts of self-harm or some suicidal tendencies. So we have to reduce stress, we have to identify, and we have to reduce stress points. Identify and discuss stress increasing points such as health issues, family and relationship problem, gender-based or partner violence, finances, stigma, and discrimination. We have to identify and discuss problems solving techniques such as stress management, such as meditation and relaxation techniques. So there's three important topic is discussed. So medical management of depression. Depression can be managed by a combination of medical and psychological intervention. Whenever needed, antidepressants should be prescribed by a psychiatrist. Antidepressant treatment is generally given for 6 to 9 months. Doses should be started with a minimum recommended dose and increase gradually. It takes 2 to 4 weeks for maximum therapeutic benefit and improvement in symptom to be achieved. Antidepressant should not be stopped abruptly. Doses should be tapered gradually. So the two main classes of antidepressant are tricyclic antidepressant, that is amitriptyline, and selective serotonin reuptake inhibitors like fluoxetine. They are most commonly used antidepressant. So mental health in children and adolescents living with HIV is very important. This is often quite neglected also. Mental health disorders during childhood, adolescence are defined as disruption in developing age-appropriate thinking, behavior, social skill, and regulation of emotion. Prevalence of this mental health condition in children, adolescents is between 6 to 12% and 7.3% in children, adolescent aged 13 to 17 years, and overall 8 to 13% of children are estimated to need mental health services. So what are the questionnaires for assessing mental health conditions in children and adolescents? Persistent sadness, persisting for greater than or equal to 2 weeks, withdrawing from or avoiding social interaction, hurting oneself, talking about hurting oneself, talking about death or suicide, outbursts or extreme irritability, out of control behavior that can be harmful, drastic changes in mood, behavior, and personality, changes in eating habit, loss of weight, difficulty sleeping, frequent headache, stomach ache, and difficulty concentrating, changes in academic performance, avoiding or missing school. So if if the person is having any of these symptoms, he will be suspected to have some mental health conditions. So referral for diagnosis and management. People living with HIV screen positive for non-communicable disease shall be referred to non-communicable disease clinics or higher health facilities for further treatment. And for ARD centers in district hospital, a patient can be referred to non-communicable disease NCD clinic. And for ART in medical college, should be referred to specialty department in medical colleges. And people living with HIV who have any of these symptoms of mental health conditions, mental health disorders like depression, psychosocial stress should be referred to undergo the screening for mental health condition. For ART centers and district hospitals should be referred to National Mental Health Program, and medical colleges should be referred to psychiatrists or other appropriate specialty department in medical colleges. So recording and reporting is very important. Documentation of screening and referrals should be documented in patient follow-up section and investigation section. Details regarding comorbid conditions should be documented in section 9 of white card, and details should be captured in IMS system also. So health promotion, screening for early detection, and referral to diagnosis and management is the strategy, is the most important strategy for prevention and management of NCD in PA people living with HIV. Health promotion. So health behavior. For various, we can encourage various health behavior and also consider the counseling sessions also. Physical activity, we can encourage them to adapt active lifestyle with moderate level of physical activity for at least 150 minutes per day or 5 to 7 days a week for at least 30 minutes each. Yoga and meditation are also very important part of physical activity. Weight control, weight management to maintain a healthy BMI. And all individuals who are overweight and obese should be encouraged to lose weight through a combination of caloric restrictions and dynamic physical activity. Not just dynamic physical activity, not just caloric restrictions. So diet, Take a balanced diet with whole grain vegetables, fruits, and pulsation. Diets shall be as per the locally available items. Restrict salt to less than 5 grams or 1 teaspoon per day. Limit use of sugar, fatty meat, dairy food, and fried food. Tobacco cessation has multiple short and long-term benefits. Encourage all the non-smokers, tobacco chewers not to start smoking or tobacco chewing, and strongly advise all the smokers and tobacco chewers to quit tobacco and support them in their efforts. And avoidance of alcohol. Use of alcohol should be avoided by everyone as far as possible. And counseling support for people with alcohol use disorder or drinking in excess of moderation. So adherence to treatment. If the person is prescribed medicines for NCDs, explain the dose, how many times a day to take the medicines. Explain how to take with ARV along with additional medicines. Explain the importance of adherence to medicines for NCD along with ART. Explain the need to take the medicine regularly as advised if there are no symptoms, and counseling on possible side effects and report them back immediately if any side effects or adverse reaction is experienced. So what is the role of nurse in these conditions? The role of nurse is to assist the medical officers during examination of patient and to assist in follow-up care, BP screening using BP apparatus. She can record the height, weight, hip circumference, and also measure waist circumference of the patient, and record the result of laboratory investigation in the survey form, and to explain the patient and the family the risk factors for NCD as mentioned above, and promote healthy lifestyle. What's the role of counselor? Counselor's role is screening for mental health, basic screening for depressions, and any patient who answered yes to either of the two questions will be screened further for depression using patient health questionnaire 9, asks for personal family history and risk behavior. The question will assess core symptom of depression to provide counseling on diet and lifestyle modification to assist in follow-up care and referral. So what's the role of medical officer? Complete history taking. It is tobacco, smoking, alcohol consumption, and clinical examination, review of signs and symptoms, prescribe appropriate laboratory investigation, confirm and recording of the findings. If the PP or RBS is high, start the preliminary treatment, record the finding in a white card, made appropriate referrals for investigation, admission, consultation for people living with HIV with comorbidities based on a finding. So management of NCDs at ART clinics. That is, ART MO sub MO can start treatment of NCDs at ART clinic itself. For diabetes, we can start with metformin, at glimepiride, or the sulfonylureas, depending on availability. And there are also various other new anti-diabetic drugs are also available, like dipeptidyl peptidase inhibitor, DPP4 inhibitors, like sitagliptin, metformin, sitagliptin, and linagliptin. They are also available, and SGLT2 inhibitors like empagliflozin, dapagliflozin. They are also new emerging drugs. So depending upon the patient condition and depending upon the presence of other comorbidities, we can start the oral hypoglycemic agent. And in those conditions with uncontrolled sugars, in spite of being on multiple OHA, and if the HbA1c is greater than 9, and if the patient has any infections, MI, or any diabetic food and all, it's better to start with insulin, and or you can combine insulin with OHA depending upon the patient-to-patient condition. For hypertension, the basic drug is to start with amlodipine, and when creatinine or kidney function test is normal, then we can switch on to ramipril or telmisartans, depending upon the availability, depending upon the conditions also, to give cardio protections and renal protections also, to prevent proteinuria also. So else you can refer to medicine department of same institute or NCD clinic or nearby dispensary or district hospital. So we can follow up if the patient has registered referral centers and review the prescribed drugs for drug-to-drug interactions. So drug-to-drug interactions, there are various drug-to-drug interactions, especially these ART drugs are very prone, are main culprit for enzyme inducers also, like cytochrome P 450 enzyme or cytochrome P 3A4 enzyme inducers also. So they can serve as substrate, they can serve as inducer, they can serve as inhibitor. So we have to take care of what regimen we are using and what OHA we are also using, especially the protease inhibitors and nucleoside transcriptase reverse NRTI. They are the main culprits for drug-drug interactions. So the challenges we face is some investigation may not be available. People living with HIV may need to go to higher centers. Patient may have to visit another facility for management of NCDs. Could be a district hospital, could be a medical college or hospital. So patterns of prescription of drugs varies from state to state depending upon availability, and complication may need specialized management. So NCDs are common among people living with HIV. They are leading cause of morbidity and mortality among people living with HIV. With aging population of people living with HIV, NCDs are going to play a dominant role in management of people living with HIV. So screening for NCDs is simple. That is measuring BP, RBS, BMI, lipids. Initial management of NCD is possible within the ART clinics, and integration of ART, NCD and HIV care is critical to achieve holistic approach to people living with HIV. So this ends my session. Thank you.
Thank you so much, ma'am. Any questions from the participants? Please feel free to unmute mic, or you can put your questions in the chat box. Any questions from the participants? Ma'am, I don't think there are any questions. Thank you so much for facilitating this session.
Thank you so much for giving the opportunity to be on this.
Thank you, ma'am. Thank you to all the participants for patient listening. We will conclude the session. Sorry. Requesting participants to please fill in the feedback poll. The feedback poll is now visible on your screen. There are 5 questions in all. Please scroll through the questions and click on the answer of your choice. Requesting all the participants to please attempt the feedback poll. Please answer the feedback poll before log out. Requesting all the participants to please answer the feedback poll. The questions and answers options are visible on your screen. Thank you everyone for attempting the feedback poll. We'll conclude the session now.